One of the first considerations that we have to think about once we've ruled out transformation in somebody with indolent follicular lymphoma is, do they need treatment at all? There are clinical trial guidelines, most commonly the GELF criteria, that help to determine whether or not somebody needs treatment. Those have to do with organomegaly, cytopenias, elevated LDH, the size and number of lymph nodes. In this case, her cytopenias and her fatigue probably do suggest that she might warrant some sort of treatment. Critically, I think the symptoms and signs that she's presenting with also determine what kind of therapy we might offer for her. The FLIPI score is an interesting tool in terms of helping us to understand prognosis. I think most follicular lymphoma physicians will include FLIPI score in their clinical notes, sort of as a reminder of where we're headed. Interestingly, I'm not sure that the original FLIPI score tells us exactly the information that we're looking for. The original FLIPI score was designed in the pre-rituximab era based on a large subset of retrospective data. And they divided a large number of people into low, intermediate, and high risk. And with an intermediate risk score, there was a intermediate overall survival at 5 and 10 years. The FLIPI was subsequently validated in a group of people treated with R-CHOP by the German lymphoma study group. And interestingly, it could pick out a high-risk population. It did a less good job of discriminating between low and intermediate risk patients. At the same time, there was sort of a drive to develop a better prognostic score. So that's where the FLIPI-2 came from. It was a group of people that had been treated in the rituximab era and had data collected prospectively. However, without longer-term follow-up data, all we can comment on is progression-free survival, which is also really dependent on choice of initial therapy. We don't have overall survival data from the FLIPI-2. And then a subsequent attempt was made to further refine the FLIPI score with the M7 FLIPI score, which is based on sequencing data from 7 genes, including EP300, EZH2, and others, for example. And the M7 FLIPI score does probably a better job of discriminating between low, intermediate, and high risk. In fact, some people that were previously determined to be high-risk FLIPI are probably low-risk FLIPI on the basis of EZH2 mutations, for example. But we don't routinely get sequencing of all of our patients with follicular lymphoma, so it's not, clinically speaking, a practical tool. So again, you go back to this original FLIPI score and say that she's high risk or intermediate risk. It gives us sort of an idea of where we're headed, but it doesn't really give us a good number to hang a hat on to say exactly how long she's going to live or exactly how long she's going to respond to a given frontline therapy.